So welcome everybody to this webinar. It is a great honor for me to introduce Dr. Stefan Ficla. Dr. Ficla is professor at the University of Würzburg in Germany. He is one of the most famous periodontists and all over the world, I can say. We are very good friends. We started to collaborate with the OsteoBeal product, with some Technos product for bone regeneration. And this evening is going to treat the issue of soft tissue grafting, established technique and new materials. So, Stefan, are you ready to start?
I'm absolutely ready.
That's great. The floor is yours.
Thank you, Antonio. What a great introduction. I'm so much happy to work with you together. Thank you for the company for setting up this technique throughout Europe. We're connected throughout Europe here. Greetings from Würzburg, Germany. You actually pronounced it very well for an Italian, Antonio, so I'm very proud of you. It's very difficult to pronounce. It's right in the center of Germany. We already actually just start to get some snow here, so it is really getting up to Christmas here. So I'm very happy to be here with you. It is sort of unreal for us always to sit in front of the laptop when we're used to be on the stage and sharing thoughts with you personally, but I think it's a great format. Actually, it's also great to share it with the moderator. Thank you, Antonio, for being here and for hosting that session. It is a great honor for me. And well, what we would like to do is to give you some insights on soft tissue grafting. Actually, what we have been doing for the last years, what is established, and what we are doing, the last weeks and months and years. And so new techniques, new materials we are coming up in order just to sort of change our treatment philosophy. And this is what we would like to discuss with you and maybe give you some insight. Now, of course, plastic periodontal surgery is something which is a very nice technique and procedure for a periodontist, because we have established our criteria over the years. We know how to cover recessions today, what techniques we can use. We know that connective tissue grafting helps us a lot in these cases, especially if we deal with thin periodontal biotypes. And this is, of course, something which has been established over the years. And what I would like to show you is at least one technique which is totally established today and is used really in daily clinical practice. Now, of course, the nice thing about plastic periodontal surgery is that we are also using it around implants today. And we know that most of the implants in the aesthetic zone, as we see it in this picture here, they are in need of some sort of grafting. And I think in the last decades, the emphasis was more on bone, so how to fix that implant in the bony housing. But today, and I think over the recent years, we think more and more about the soft tissue mantle, about the soft tissue integration of the implant fixture, especially if we deal with the aesthetic zone as we see it here in this picture. So actually a lot of these techniques we have been using around teeth are more or less transferred now to the implant side and help us to achieve better aesthetic results, but also, in my opinion, to establish better functional results, because we can start using these techniques also in the functional zone to reduce the incidence of complications like peri-implantitis. Now, the most thrilling about this is this. When can we use these membranes? Are we actually already at that point where we can say, yes, this is the new connective tissue graft? So this is a porcine membrane. It's called Derma. It's manufactured by OsteoBeal. There are not so many soft tissue grafts on the market, porcine. So the question really today is, when can we use it? When is it safe? When is it maybe just still too risky? And well, has it already replaced the connective tissue graft? And what we will try to do is, Antonio and me, we will give you some honest ideas from our offices and from our daily clinical practice when we're using these membranes, and where we are rather careful with these membranes, because of course everything is a learning curve when it comes to these new materials. Now, soft tissue volume is the basis for recession coverage. This is, I think, one of the most important things. If you want to cover gingival recessions, you need to think of augmenting tissue volume. We always deal with thin parental biotypes, and if we just transfer some tissue which is locally around this receded tooth more coronally, we know that we will have rebound, we will have receding tissues again. So recession coverage needs to be connected with tissue augmentation, soft tissue augmentation today. And this is nothing new. A lot of research, actually, a lot of this research comes from the Italian group. Also, Antonio, I know you have been doing a lot of research in that field. So we clearly know today that that soft tissue grafting, especially the connective tissue graft, they seem to be superior to other techniques, or they seem to be superior to just simple flap techniques. I mean, if you ask me today what is the best technique for covering recessions, is it a lateral reposition flap, is it a coronal reposition flap, or tunneling techniques, I probably couldn't really tell you. But what I could tell you is that if you're using one of these flap techniques, you should combine it with something. And the combination, of course, the gold standard is still connective tissue. There are biologically active molecules like enamel matrix derivative, and we will discuss today about the dermic membranes. Now, there's a really nice study which really comes together with the thinkings we have is they looked up to 10 to 27 years in patients where on one side they did recession coverage with soft tissue augmentation and treated recessions, and on the contralateral side they didn't do it at all. And what they did after these long period of time, they looked at these sites again, and what they found out that there was pretty much tissue stability in the sites which were covered, and there was a tendency for further recession and further receding tissue in the areas where there was no soft tissue augmentation. So I think this is more or less clear today that if we cover recessions, if it is around teeth, if it's around implants, we need to augment soft tissue volume. And I think this is why we're here to discuss that. Let's look at one of the established techniques. I think this is a clear case for recession coverage. Most of these patients are young patients with rather thin parental biotype. We have sort of similar recessions as we see it here. And of course, this is a case for a tunneling technique, meaning that we are trying to avoid incisions as much as we can and try to undermine that situation and add connective tissue to coronary reposition the flaps and also thicken the biotype. I brought a video for you in order to really look in detail at the procedure. This is the clinical situation. Of course, make sure that these patients are pre-treated very well because it's an elective surgery and you need great tissue for these kind of surgeries and mature tissue. We always start with circular incisions. We try not to cut through the papillas. We only try to get an access with our small blades. Here in these cases, these blades can really be helpful, these small blades. Now, if you want to cover here from canine to the first molar, you have to extend your preparation to one tooth adjacent, which makes it, of course, also a traumatic surgery. We have to be clear on that, and also undermining the tissue means that there will be a lot of swelling accompanied in these kind of patients in these kind of treatment scenarios. Now, we have special tunneling techniques, tunneling instruments, which we use to undermine this whole complex here, and ideally in a split thickness fashion in order really to retain the blood supply, retain the periosteum on the bone, and also to have a little more tissue flexibility for these kind of situations. Now, you see, this is the motion, how we start to undermine this tissue and get access to the situation. Normally, you can't really believe that this will really be mobile at the end of the day because it's still attached all around. It's actually attached around the papilla, it's attached in the apical part. but the further you go over the mucogingival junction, you will gain some tissue flexibility. Now, the papillas are sort of, well, just a little bit loosened up. We don't want to detach the papillas, and now you see what happens by this preparation is we gain mobility. Now, this is the way we always proceed in these kind of cases. We do the recipient side first, then we go to the palate, and of course this will be one of the disadvantages we will discuss today is do we still need to do that actually, or can we use our dermic membranes for this? I think we will have an answer for you at the end of the day, and of course the answer will not be so simple, but it will be yes, in certain cases we can, and in certain cases we can't today. Now, we undermine the palate, we try to use these kind of singular incisions, we try to avoid trapdoor incisions, and cut the connective tissue graft here, and then start to loosen it up to retrieve it from the palate. In most of the cases, we have to do it in a split thickness, in a full thickness fashion, because of course the buccal area is thin, and most of the cases the palatal area is thin too. I see this is the kind of grafts you can harvest from the palate. Of course, it's possible, but the question is, can we avoid it? And well, can we do something good for our patients if we have something equivalent which we can use in this context? Now, what we do in these cases is we just put a little pressure on this site and try to fix this with the continuous interlocking sutures. In the earlier times, we used templates in order to cover that again. Today, actually, I tried everything. I tried fibrin, I tried collagen, I tried glue. Today, I'd say I just do an interlocking suture as a continuous suture here, and well, leave it like it is. I just saw the best healing with these kind of simple closures as we see it here. Now, we go all the way back to our recipient side, make sure it's still moist and it's not dried out, and then we use a suture to move this graft into this created tunnel. Make sure is you use the backside of this needle in order to sort of bring in the first part of the suture, and now we sort of fix it, the connective tissue graft, and go all the way back, and at the end you will see you will have this connective tissue graft. You have it like a fish on the hook, and then you can start to move it into this tunnel. You hand your needle holder over to someone you trust, and then this one gently starts pulling the connective tissue graft into place. So you see it moves in this envelope, and then you can ideally position it wherever you want it to be. Now, if you want to be on the perfect side, you can also do this suture to from the distal again. See, coming from the second molar here, going all the way through from 7 to 6, and now the way back. And now you have this connective tissue grafts on these two pieces, and you see you can ideally position it where you want it to be positioned. Now, suturing it up is quite difficult because you can imagine you need some tissue strength, and well, you need some power to bring this up. This is actually one of the disadvantages of these techniques, is that it's not completely tension free. You see, we try to move it up with this kind of modified mattress sutures, which is just well closed over the contact point, and by this way this whole tissue is moved up into that direction. You see, in some cases we use some additional macrosurgical sutures in order to move it up completely. Okay, now we can go back to the slides. Again, this is a clinical view. You already saw that, a detailed view, and then the post-op situation directly after surgery. You see, in some cases you can really just have a little bit of tissue looking out of the canine. If the graft is big enough, you can do that. If you rather have a small graft, rather be careful not to have it stick out too much. Then the healing, and this is what is surprising us now in these kind of established techniques, tunneling techniques. The healing is much better than we used to see it around our classical techniques like the lateral reposition flap or the coronal reposition flap. And it's pretty much clear. I mean, there were no cuts done. It is not, the papillas are not cut, and it's only actually undermined. Again, the baseline and then the final situation with, in my opinion, an acceptable result. But what is driving for me is that the tissue quality, the thickness, the obtained tissue quality without any scars. And this is, of course, in my opinion, one of these established techniques we have today is connective tissue grafting with tunneling techniques. Well, this seems to be a technique which works very well, and first research comes up from Otto Suhr here, showing that these techniques seem to have just better results than we used to see it. Root coverage in 98.4%, and even more striking is complete root coverage in nearly 80% of the cases, which actually was never reached with these old techniques. However, we have to be careful. I think there still needs to be some research coming up. I already told you there might be some drawbacks in this technique because the deeper the recession gets, the more tension you needed to bring it up. There are probably some of the disadvantages, but today I'd say one of the established techniques to cover gingival recession is, of course, a tunneling procedure combined with a connective tissue graft. What about implants? Can we use connective tissue grafts in implant sites? And of course, we need them in the aesthetic zone because we lost volume in a lot of these cases. And of course, we can build up the bony site, and we have to build up the bony site in a lot of cases, but in a lot of cases, we also lost soft tissue, which needs to be rebuilt. And this was actually always, from a research point, the most weakest area if we talk about soft tissue grafting, because there was pretty much no research on this. I mean, no one really knew, is soft tissue grafting good in the aesthetic zone? Is that something which is established? Well, I think also some research starts to come up. This is very recent from this year, from the Peri 2000 magazine, and it's actually the first time that I saw that, is that the authors really state that, well, a certain amount of soft tissue thickness seems to be important for long-term stability. I mean, in the earlier times, everybody was talking about bone tissue, how much bone we need in order for long-term stability. This is, for me, actually one of the first studies really pointing out that soft tissue thickness seems to be important if you want to maintain tissue stability. Now, what is an established technique in the field of, well, implant dentistry when we talk about the aesthetic zone? And of course, we today will look at the aesthetic zone. This is clearly something where we need soft tissue grafting. I mean, we have a central incisor, as you see it here. It was lost because of trauma. This tooth was then removed without any socket preservation, any grafting, and what you see is that is the provisional phase some weeks after tooth extraction, and you already see what kind of invagination you get after these kind of extraction procedure. This is what we clearly know, and Antonia, I know you're one of the renowned experts in the field of the extraction socket. We clearly know today that when we don't do anything at the time of tooth extraction, it looks like this. And we will have the problem of fixing the implant. We'll have the problems of making a nice gingival outline. So of course we would today say these extraction sockets should have been dressed with some kind of rich preservation techniques. Now, this is the situation after the provisional was removed. And of course, I mean, we need some kind of augmentation. I mean, how are you able to aesthetically integrate an implant into this situation without a rich lap design or without an overlapping design? For me, this is actually not possible. I mean, this is something where probably bone needs to be augmented, but also soft tissue needs to be augmented. This is the clinical situation, and this is clearly the situation we've been used to see in our control groups, Antonio, right? The control groups in our studies were always no socket preservation, and pretty much they look like this. Am I right?
Yes, totally.
So I think this is, well, it's not the base of this lecture, but I think a lot of things could have been better in that case when we would have done something to preserve the socket. Now, implant placement, and of course we can discuss a lot of things about placing these implants simultaneous or doing the bone graft beforehand and then placing the implant. I think this is up to discussion, and probably already changed my attitude a little bit more again. Maybe I would have been more conservative today in this case. In this case, I had a rather contour defect, which was more or less self-supported. So in this case, I thought it might be a good way to do it in a simultaneous way. Even more important for me is how we do the soft tissue management today. Make sure you only do one vertical releasing incision. It's way enough. Do not do a vertical releasing incision here. I mean, this makes your life so much difficult. This is what we learned from recession coverage. You've taken away blood supply here. You make your suturing difficult. If you do this in a little bit of a C-shaped incision, which meaning like a cutback here, you have so much visibility, you have so much access, which is actually totally enough for everything what you can do here. Now, this is the clinical situation. Of course, up to discussion what to do in these cases. I think there are different roads to go. In this case, for me, it's a self-supporting defect. So for me, a case for a collagen membrane and a supporting bone graft. In this case, I'm tacking the membranes in order really to have it very much stabilized. But in these cases, I'm augmenting soft tissue also. So I will use connective tissue graft underneath the flap, and I will extend the flap with my connective tissue graft and have an additional volume built up, and also at the same time I have a second site where I'm avoiding secondary wound closure. Here's a schematic drawing how we use that normally. We suture that at the inside of the flap with a little bit of incongruency, as you see it here. I'm getting this arrow here, a little bit of incongruency here, and this is the situation. We then move underneath this palatal flap in order to have sort of a secondary layer of wound closure here. Now, clinical situation, everything sutured up. You see the implant in place, you see the tacks in place. You see the situation sutured up, and for me, just easier. I mean, if I have one vertical releasing incision, it's easier than if I would have two in these cases. Now, then the healing of this situation, of course, you shouldn't overdo it with the volume augmentation and the bone augmentation at the same time. You should always try to have a good and tension-free wound closure in these cases, but in our experience, if the soft tissue management is well, it can be obtained very well in these cases. However, also after volume augmentation, soft tissue augmentation, we still see some relapse. And if you're really in the aesthetic zone, you might have to rebuild that again. This is a classical case for me for a roll flap where we just use the tissue, which is over the implant fixture, and just roll it into a small pouch which is created on the buccal side. Then we use provisionals to establish the emergence profile. This can only be done if you have enough soft tissue volume. If you don't have enough soft tissue volume, you cannot manipulate the soft tissues in these cases. And then we save or we secure these soft tissue profile with this kind of individual impression copings, transfer that to the lab, and then integrate the final restoration in this case. Today, I'm also already in a sort of a transition. Antonia, I don't know how you are doing that. We actually have been using screw retained prosthesis more and more. It just seems to be easier. It is, for me, easier to remove the cement. It's easier for me in the clinics. It's easier for me to obtain the nice emergence profile also in the functional zone. So this has pretty much changed in my hands. So we really sort of moved to screw-retained prosthesis today. Now, this is the final situation. Now, where are the drawbacks? And of course, this is why we're here today. We're here to look at established techniques, but this is what all of you know. So it's just a sort of a summary where we're using these kind of techniques. So you saw tunneling techniques with use of connective tissue grafting. And you also saw that the implants where we're using the connective tissue graft. Now, where are the drawbacks? And of course, the drawbacks are there. We have these problems which are on the palate and which may not only be because of complications, but it is also a matter of just patient management. I mean, we all know, I mean, at least in Germany, I always know what happens if I come up to the patient and tell him, I just need to remove a small piece of your palate. I mean, they don't really like it. And this is why we're thinking about alternatives in this context, using membranes, dermic membranes, xenogenic materials in this context. Of course, we see secondary wound closure, and this is just patient problems. We see, well, a limited amount of tissue, as you see it here. Normally, we just find tissue underneath the two bicuspids. We, of course, see complications, as you see it here. This is not the big palatine artery, but this is a small artery which we opened here. And, of course, we see also some kind of long-term complication. You see here, this is a secondary healing, this is a bone denudation, and this can be of major problems in these kind of situations. Now, just this year it came out, we did a comparison between two harvesting techniques. One is the established technique of trapdoor incision, meaning that we're using 2 or 3 actually incisions, 2 vertical as you see it here, and 1 horizontal to more or less reach the tissue in the palate. And we compared it with a single incision technique here, and what we found out is that significantly the single incision technique was better than the other technique. I mean, look at the other technique, trapdoor technique. In nearly 70% of the cases, you had sort of a secondary wound healing, meaning you had additional patient morbidity. And even with the best technique, which is a single incision technique, we had 25% of secondary wound healing. So, of course, we see complications, which may not always be huge complications, but if we can avoid them, this would be good for us. And I mean, if we are talking about a technique which is the best we have at this moment, but still shows 25% of secondary wound healing or complications, then of course we need to think about, well, alternatives in this field which, well, can help us to maybe serve our patients better in this context. Now, where are we today with xenografts? Where are we standing, and what is the research telling us? Of course, we do not have these kind of long-term studies and long-term research on these products, but I think we can give you at least the research we have at this moment and our clinical feelings with regard to these materials. So, what do we have? What kind of materials? And of course, we have different materials on the market today. We will talk about these dermic membranes, which are, well, made out of porcine dermis. The epithelium is removed, and we just have this kind of skin here where the epithelium is removed. We also have sort of more loose tissue, which we can use in this context, like collagen. However, we will focus today on these kind of more dense or fibrid tissues we have here. There's some research, of course, if you use these kind of materials, these xenografts, of course it's less morbidity, patients like it more. I mean, I think this is pretty much obvious. And of course, there's significant less surgery time. However, I always have the feeling that also with these new materials, it's a learning curve. I mean, you have to adapt them, you have to trim them, And if you are rather experienced with connective tissue harvesting, I'm not sure if it really takes so much longer to harvest the connective tissue graft from the palate, because, well, most of the cases you can already ideally harvest it in the size you want to have it. So, well, what are we talking about today? We're talking about these kind of matrices, osteobioderma. I already told you it's derived from porcine origin. The epithelial layers are completely removed. It is a resorbable material. We have it in different sizes, well, 2 to 4 millimeters, which is actually really, really big, because it also, just remember, it also sort of soaks water and gets rather bigger in the wound. That was one of our experience we had. So with these membranes, make sure you rather use a little smaller ones than the volume you want to achieve, because these dermic membranes, they sort of, they swell up a little bit in your wound, which of course increase the pressure and increase just the trauma. So these are the different materials. Fine, just 0.8 to 1 millimeter. I would think it is about 1.5 millimeter in the final clinical situation when it's really integrated into the flap. Now, of course, the first question everybody asks, I mean, are these materials safe? I mean, can I really place them in my patient's mouth, and will they integrate without any, well, foreign body reaction, or will there be any, well, necrosis of these materials, or will I have any problems with these materials? And this is actually, this was also our first question we had with the manufacturer of these materials. And I really like it that a company says, okay, then we do some kind of histological analysis if these materials really integrate well into the body. And what we did, we went into the animal. This is a canine, this is an upper canine of a dog, and we compared a connective tissue graft for recession coverage of a canine. This is a connective tissue graft harvested from the palate with these kind of porcine dermal matrices. And we looked at, well, we looked at tissue thickness, we also looked at coverage, and of course we histologically looked at the situation and wanted to see if there are any foreign body reaction or any problems associated with it. What we found out is that these are, this is one of the histology of this study, is that these materials actually integrate very well. We are not sure if the resorption time is really 4 months. They were still, after 4 months, we did the histology after 4 months, and there were still tissue remnants. As you see it here, there's some tissue remnants of this material, meaning that probably some parts of the material have a resorption time, which is probably longer than this kind of, well, short period of time. Even more interesting for us was there was actually no foreign body reaction. We saw very, very small amount of immunologic reaction, and actually also the clinical situation were pretty much comparable. So tissue thickness was pretty much the same, and also recession coverage was pretty much the same. This might be discussed if this can really be transferred to clinics from the dog, but interesting enough is it seems to be that these materials, they work fine, they integrate, they resorb, they are replaced by patient's own material, and actually this is a good sign we have for these kind of materials. Now, let's go into the clinic. When are we using these materials, and where are we careful with these materials? Where we see that these materials work very well, and where we have the feeling that these materials are still, well, we still need a little more information and also a little more, well, experience with these materials. First of all, of course, we start rather with thick parental biotypes. We rather start with situations where we are rather more on the safe side. Singular recessions where we are thinking, okay, we can limit the amount of this tissue. In this situation, we had a recession on the upper molar, on the mesiobuccal root. You see, it was sort of a prominent root, and we have the recession in this case. Now, this is a classical case in our hands for a lateral reposition flap. So, meaning we are sort of use tissue harvested from this situation and swing it over the root. And in this case, as we had a thick tissue, as we had a good clinical situation, this was actually a good case for a replacement material, xenogenic material. Now, the derma is adapted, as you see it here. Try to make a cross suture. This is a cross suture which is anchored around the lingual or the palatal aspect of the molar. And this is a suture which should be well torn down with a little bit of pressure, because you want to have some pressure on this material, because you don't want to have a blood clot in between and sort of having the problems with the healing here. Now, material adapted, and then the flaps repositioned over it exactly as we used to it. This heals, the situation here heals by secondary intention, as you see it here. This is just partial thickness flap, and then this flap is transposed to the mesial aspect, sutured in place. Not too much tension, not too much pressure on the sutures. Also, one clinical trick: rather suture with a little less tension when compared to connective tissue grafts. Why? Because these materials, they swell up. So if you already have a suture with a really high tension and a high pressure, and now this graft inside, or this membrane inside, swells up now a lot, then maybe the pressure can be too much in some of these cases. So rather be very careful with flap tension when it comes to these kind of surgeries. Now, this is the healing, and of course we have to admit one thing: the healing is of course a little slower than we are used to around our autologous materials. But I mean, this is clear. I mean, we're using a foreign body, we're using some kind of material which has to be well resorbed and has to be well looked at from the body as a foreign material. So we see acceptable healing with these materials, but we do not see the same quick tissue healing that we see it with our connective tissue graft. However, we monitor up these cases 10 days, we remove the sutures, and you see actually a nice situation already now after 3 months, the situation here, and this is what you see. It takes a little longer than we used to, but just give the tissue the time, and again, this is the situation from the outline, and then the final situation now after 1.5 years, just corrected with this lateral reposition flap and a dermic membrane, in this case a derma, underneath it. Even more striking for me is not the amount of complete root coverage, but is the thickness of the tissue here. This is the important thing, and this is something what we really want to hold up, and this is actually what we monitor and can't really tell you. Is that going to hold up for years? We don't really know today. Actually, these are cases now 1.5 to 2 years. It looks pretty good, but we have to see what's happening after 5 and 10 years. Now, what about multiple situations? Can we use these materials in multiple situations? And yes, of course, the same thing. We're rather going to more safe situations in the beginning. Here you have a clinical situation with, I'll go back one more time, with sort of mediocre recessions, not too big. We start using our material here. Here is the membrane already soaked. Also, one clinical tip, which I made a mistake in the beginning: make sure you really moisturize these materials for 20 or 25 minutes. Otherwise, they're so hard and so difficult to manipulate. It's very difficult. So make sure 20-25 minutes should be moistured. If you still have these thick materials, this was one of the thick materials, we sort of thin it out in order not to get too much pressure on the flap. Now, this is the situation, already the same suture that we're using with these kind of sling sutures and these kind of anchorage sutures in the contact points. And then the healing, good healing actually, not as good as we're used to it, but I think we expected that. And then the final situation now after a year, this is actually something we really see with these materials. If this is a good clinical situation and we are on the safe side when it comes to the biotype and it comes to the tissue integrity, we can achieve acceptable results with these materials. Again, the comparison from the outset and from the final situation, actually an acceptable situation without any harvesting of connective tissue grafts. Now let's go one step further. Can we use it around implants, and when can we use it around implants? Because this is probably also something interesting for us. I mean, these patients already had to undergo implant surgery, so can we maybe avoid these kind of situations? And what we found out is that for these kind of indication, it really works very, very well. We have a closed situation. We use it at second stage surgery. Here the implant is already inserted. The implant is already inserted at this time. We do the second stage surgery now. Crestal incision. We do a small pouch preparation on the buccal side, if possible as partial thickness flap. And then we use a small piece of this material, of this derma material in this pouch. We use it directly underneath the flap, and then we resuture everything back. In most of these cases, I don't even suture these materials by itself. I just resuture the edges of the flaps, and if you see this amount of volume augmentation, this is really something which helps us as clinicians. I mean, we can just use some better emergence profile. We can help the patient also with the oral hygiene. Now, again, start from the outside. From the outset, this is the clinical situation at the time of second stage surgery. You see this incongruency here, and then the final situation with an acceptable volume augmentation, in my opinion. Let's look at a second case, even more incongruencies or even more concavity. And of course, you see, we started to use it in these kind of functional situation in order to get a feeling for these kind of materials. Same situation, you see the implant was already in place, was the time of second stage surgery, use these membranes into this buccal pouch and resutured everything, in this case with these kind of atraumatic sutures. And of course, in this case, we get a little bit of relapse, but if I look at the situation from the outset, we definitely have an improvement in these kind of situation. Again, the clinical situation at the time of final reconstruction and with the final reconstruction in place now. And you actually see that the situation is improved. It's not perfect, I agree, but it is improved when we compare it to what we saw in the beginning. Now, let's go one step further, and you see we started to build up our experience and go more in detail with these materials and try to use an even more sophisticated indication, because we see huge potential in here. Can we use it to augment attached tissue? And well, there is some research on the market with different materials looking into augmentation of keratinized tissue, which is a major topic, of course, in the functional zone. And they found out that it seems to be similar to connective tissue grafts, and of course, it has less patient morbidity. For us, this is still the most difficult indication we see, and to be honest, this is not my preferred indication for these kind of materials, and I'm always honest when it comes to the clinical view. I think in these cases we still need connective tissue grafts, or in this case actually we need free gingival grafts to augment keratinized tissue in this situation. Probably we need this biological background of this tissue. In this case, we used one of these membranes. We had some medical issues with the patient, and I just want to give you these examples that it may be a compromise. In some cases, you can attain a certain amount of attached gingiva, however, not comparable to what we saw when we use autologous tissue. This is the healing, and actually when I see this healing, I thought this is it. I mean, I'm not going to use any free gingiva grafts again anymore, but what you will see is the relapse is rather big with these materials if you use it in an open fashion. So this is the second thing which seems to be of utmost importance for me. With connective tissue graft or free gingiva graft, you can play around. You can use it in an open fashion, you can use it in a closed fashion. With these membranes, you have to submerge it. It is, most of these materials work better when you submerge it, and then the final situation. And of course, this is a compromise for me. It is not comparable to what we saw around our classical augmentation procedures, but it may be a compromise in some cases. Now, do we have disadvantages? And this is what we need to talk about also if we talk about these materials. And do we have disadvantages, and when do we think we see these disadvantages or complications or problems? And I already told you, we see problems when this material, first of all, when we overstretch the indication, meaning we have to put too much tension on our flaps and then have to coronal reposition these materials too much. And the second type of complications we see is when we use these materials in an exposed fashion. Not really complications, but then just the clinical value is not that we can use it on a daily basis. Well, we started to use it around multiple recession type defects and did this small case series which was published last year. And you see, well, we treated 28 gingival recessions. We were multiple recessions. We reported no complications. However, we also reported 65% of mean root coverage, which is not that overwhelming, to be honest. So, of course, make sure these materials still have their limitations. They are in a learning curve. Of course, this was when it was published 2013. We started probably with this study in 2011. So this was the beginning time we used these materials. So of course it's a learning curve, and of course we probably overstretched the indication of these materials. This is probably something we can discuss afterward when we're using this membrane. So what would I say today is when can you use these materials, and when should you be careful, and what should you do? And of course, for these materials, for me, it's even more important to retain the blood supply. I mean, it's important for all of the techniques we have, but for these materials, even more important. It's a dead material which we use here. It has to be nourished by diffusion. So this is really something we need to make sure. So of course, use small instrument, fine instrument, use magnification devices, use flap techniques which do not have so much trauma on the tissue like tunneling techniques. On the other side, what we also see is that the healing response of these materials are worse. So try to add some wound healing enhancers, I called it, and this can be different materials. This can be, of course, animal matrix derivative. This could be sort of a PRP or some kind of PRGF. So of course this is really something what helps us with these materials to add a little bit of extra wound healing with these materials. Now let's look at at the end of my presentation, let's quickly look at a video where we combine really these materials with the grafting of these dermic membranes. We combine it with animal matrix derivative in order to boost the wound healing. And again, let's look at the indication, and you see we are careful. We are still careful. These are sort of light indications where we're using these materials, and I would suggest the same thing for you. It is a learning curve. Start to use these materials rather carefully. They are technique sensitive because with respect to trauma, with respect to what we're having with the tissue stability. So these materials are not easy to handle, and of course soft tissue needs to be handled very careful, and this is what we see with these materials. Same approach. So from the onset, let's try to retain blood supply as much as we can. in order, well, to get as much diffusion as we can with these materials. So this is what you already saw, tunneling, undermining of these envelopes here. Make sure everything is connected. Make sure you get some mobility as we see it here. Try to move up the papillas a little bit. In this case, you see we opened this mesial papilla, as you see it here. In this cases, you have to do it, otherwise you can't integrate these membranes into this tunnel. You will not be able to integrate it via this tunnel here. So then this sling suture, or this sort of additional suture we're using here, you see we sling this graft, and now we're already in the right position. We move it in our envelope, and now comes this part we're using additional materials to boost up the wound healing. This is animal matrix derivative in this case, in order just to increase the wound healing, in order just to, well, do something against the drawbacks or the problems of these materials. So this is what I would totally advise you to do. We do not have the same healing capacity. Okay, of course there are foreign bodies. So at this time I would think, especially if you're using it in sort of, well, sophisticated indications, make sure you use something on top of it which improves the wound healing. And just imagine, I mean, how much tissue has to be replaced and how much tissue has to be nourished by the body. It is really a big chunk of tissue, and if we can support our tissue with this, this would be great, and I would advise you to do so. We suture these materials directly, meaning we put the finger on top here. In most of the cases you can feel it. I can't see it anymore. You feel where this membrane is, you shovel it up a little bit, and you go through it with the needle and really position it at the coronal aspect. Now, this is the clinical video at the end, and this already makes me going more or less to my summary, and I hope this brings up the discussion now is, where are we today? And Antonio, maybe you correct me, maybe you have a different experience where I would be thrilling to hear. So I think, and I'm always honest, and I think connective tissue grafts are still the gold standard. And this is the standard of care we have, and this is the evidence we have. And actually, this is what we're doing in the field of recession coverage, and this is what we're doing around implants. We're more or less going our way into the field of porcine membranes, and we are using it on a routine basis today around mild recessions, mild gingival recession. Make sure you don't suture it too heavy. Make sure you moisturize it enough. Make sure you use some kind of additional wound healing expander with it. I think the most predictable situation, or the most predictable surgery with these kind of materials today, is volume augmentation. These materials, they work very well if they are used in a submerged environment, and this can be attained very nicely in well, at the time of second stage. And this is for me just the major indication at this time. Volume augmentation in the functional zone. We start using it also in the static zone, just to bulk up the volume. Make sure it's in a closed environment. Don't let it let it be opened or let it be exposed. Make sure you start with some kind of areas where you have a mild indication, because these materials, they have a learning curve. And the learning curve starts already by having it moist enough and having it smooth enough for your surgery. It also already starts by having it at the same size, at the right size, because remember, it expands in the wound and then can put pressure on the soft tissue and may limit also then the tissue nutrition and the tissue blood supply. Atraumatic surgery is of course important and is something we've been using around all our surgeries, but this is, I think, for me even more important. And I think this could be also a field where we're using additional growth factors. May not be growth factors which we really have to invest a lot of money. But it may already be some kind of animal matrix derivative or some blood-borne agents we can use in this context. This was it from my theoretical background. I hope I brought up some maybe interesting point. Maybe some of the points are already settled, but I hope, Antonio, you agree in more things with me than you disagree. I'm hope we have some questions, and I already hope you have some questions. And yeah, let's try to bring it up into the field of question and answers.
So, Stefan, I have to admit that you did a great lecture. I really appreciated it, and I really improved my skills in periodontal surgery. So, thank you very much. Really happy for this lecture. We saw great clinic results, and we saw a lot of scientific studies from your lecture. So I really appreciated it. I see that we have a lot of questions, I think, for you.
Good.
So I would start from the beginning. Can you see the question, Stefan?
Yeah.
Stefan, can you see the questions? Yeah. So
yeah, I can see.
I will start from I will start from the beginning. I mean, from the first one. When this flap heals, will it still visible since it is in the static zone? By Ivan Evans. I think the question is referred to the flap management in the static zone.
Yeah. You think it is a question because of this the vertical incision?
The vertical incision. I have to be honest and have to say that I totally agree with you. I normally do for the static zone just one releasing incision far away from the surgical side. So I totally agree with you. I think that the question is related to the fact that you did the releasing incision still in the static zone. Do you think can be visible even after surgery, or would you prefer to stay more, far from the surgical side?
Yeah. Actually, I did it in the earlier times to go one tooth back. I mean, let's go to the distal aspect of the canine and to sort of hide this incision behind the canine. Today, I have the feeling, because then I have to remove the papilla between the lateral incisor and the canine, where I also think this might have disadvantages. Today, what I think, if I do it perpendicular, meaning really at the distal line angle of the lateral incisor, and I go perpendicular from the sulcus in a really rectangular fashion, and I can really readapt it very well later, I don't see so much relapse in these cases. Of course, there can be little scars in this area, but I really never encountered too much problems with the releasing incision on the distal aspect of the lateral incisor.
Okay, thank you. And then we have the next question by Yvonne Evans again. Can you read it?
Yeah.
In hygiene, do you find that cement accumulates around those implants that are not screw retained? And again, I totally agree with you. Yes, we definitely are moving toward the screw retained restoration over implants. No way about that. So would you say something about the question, Stefan?
Yeah, I mean, I totally think that it is very, very difficult to control cement remnants. I mean, I know that there are different tactiques, cementing outside the mouth and then bringing it into the mouth. I am totally convinced that it is very difficult to remove cement remnants from the sulcus. And this is already difficult when you use a provisional cement, but I think it's even more difficult if you use it in an adhesive cement. So for me, even if you go in an equigingival fashion with an individual abutment, for me, this is not manageable. I mean, this is maybe acceptable in patients who are not prone to infection or disease, but what we see in if that happens to you in perio patients, you're gone. I mean, if you have cement remnants in patients with a perio history, this is really provoking disease progression. In my opinion, it's very difficult to control. And actually, I think it's much easier to screw retain these situations in the clinical daily basis. It's just easier for me to come into the patient and screw retain it. I mean, just easier and I mean more predictable. I don't see so many disadvantages.
Yeah. So we can say to Yvonne that we probably are moving toward the screw retained restoration over implants because it's easier, because it's probably far risky, because some of the recent systematic review about periimplantitis showed us that most of the periimplantitis infection around the implant can be related to the presence of cement. So I totally agreed with Stefan, and try to use, if you can, screw retained restoration. So next question by Yvonne again is, are there any other site beside the palate to harvest? Yes, I think that there are some other sites, but please answer this question, Stephanie.
Well, I think, of course, we can go to the tuberosity. This is actually an area which we like pretty much because we have much more fibrous tissue, which seems to shrink less. However, I mean, especially if you look to these multiple recession cases, the tissue is just not enough in these cases. It has just a weird size. It's sort of a wedge, and we really cannot use it. We sometimes use it for edentulous volume augmentation, but in most of the cases, yes, the palate is the case where we remove our connective tissue graft.
So moving toward the use of derma, I see again some other question. Is the membrane, the derma membrane, similar to Emdogain or alloderm?
Yeah.
Stefan,
actually, it is sort of a similar material. Oh, I'm sorry. Yeah, it is sort of a similar material when compared to alloderm. Of course, alloderm is of human origin and is, I mean, at least in Germany, it's not on the market. And I don't know how it is in different countries around the world. Of course, in Germany, it's not on the market and has no CE sign. Emdogain is a totally different thing. Emdogain is an animal matrix derivative which has been established for regeneration of bony defects and is today used for wound healing and expedite of wound healing. So yes, it is rather comparable to alloderm. I worked with alloderm in my time in US. I had the feeling that, I don't know about you, Antonio, I have the feeling that the relapse with alloderm seems to be a little bigger when I compare it to derma, but this is just my clinical feeling.
Yeah, I totally agree. I totally agree with you, Stefan. With alloderm, you probably have some recession, I mean, some relapse treating the recession, and I would say I strongly prefer the derma because it's, I mean, we have several thickness of derma. So you can choose probably the thickness which is, I mean, best fitted in the case you are going to treat. We have another question by Yvonne Evans, and the question is, are you only concerned about volume on the buccal plate? I think she's speaking
I'm not sure if I understand the question. Yeah.
I think that she probably is talking about the treatment of volume loss, and we are concerned about the buccal plate because it's one of the side where we have volume loss. That's the only reason, I think. Do you have any other interpretation about this question, Stefan?
No, I mean, I think this is perfectly answered by you. And of course, I would hand this question over to you because you are the expert in the field of extraction socket management. And of course, we see that we lose tissue. I mean, two-thirds of the tissue we lose on the buccal
Yeah,
side. And this is where we are concerned.
yeah. So we normally have around 2 millimeter between 1.5 and 2 millimeter vertical loss after tooth extraction, and we have some horizontal loss after tooth extraction. And normally, what can be, I mean, what really it is a challenge for clinician is try to manage the volume loss at the buccal side. So this is probably the reason you need to treat the buccal loss. I mean that's the only answer I can see for this question. So going to the next one, did you use our tissue augmentation as well as the allograft?
The question probably goes into the direction if I would combine a hard tissue augmentation with an allograft or with a dermic membrane. Actually, I still would be careful. I mean, what would you do, Antonio? I mean, I always have the feeling you overstretch biology sometimes too much. And you have a xenogenic material, bone material, then you have a membrane in there, you have a dermic membrane in there. I mean, if I have a huge bone augmentation, I would rather not combine it with soft tissue, or if you want to do volume augmentation at the same time, then I would really still use connective tissue.
Yeah, I totally agree with you. Don't stretch too much the biology, and we have to realize that the xenografts are excellent biomaterials, but you have a sort of delay and healing every time. So if you combine hard tissue augmentation with xenograft and soft tissue augmentation with a xenograft, then we can combine probably too much. I mean, I don't know. I don't have actually any answer, but I would just suggest just to be careful about that. And combination of too much xenograft can be sometimes even dangerous. What do you think, Stefan?
Absolutely. Don't overstretch it.
Okay. So next question, like infection or inflammation with the use of derma?
Yeah. Well,
Stefan.
we actually see that. Also, let's come back to what we said. If we overstretch the indication, I mean, we saw some problems when we used the membrane too thick, meaning it expanded in the wound. I'm not sure. I would be interested if you figured the same, that these materials they swell up a little bit, and you have to really be careful with the wound closure if you do it like you're used to. So we see some, of course, we see complications. I mean, if you do dentistry, you see complications, and we see complication with these materials. They have a learning curve. However, what we see, if they are exposed or if these materials are denuded, we also see that under chlorhexidine and just local agents, it heals up pretty okay. I mean, you will not get the result you will want to have, but we don't see too many detrimental effects like we saw with the let's call it with the non-resorbable membranes. I mean, if these materials were exposed, we were really in trouble. I mean, we don't see that so much. I mean, we see, of course, exposure, and then we handle it in a classical way with topical administration, with systemic antibiotics in some cases. We see a healing in this situation. Of course, it is most of the times a compromise, but we don't see a really dramatic complication with it. What is your take on that, Antonio?
No, the only complication I mean can have is probably an exposure of the membrane, and but I have to be honest that every time I saw that kind of complication, you can even observe that and see that the membrane will resorb quite fast. So it's not really, I think, a real complication. Sometimes you can have a sort of relapse for the recession, and that's it. That's my point of view. So, Stefan, I have one more question for you. What do you think about the harvest of the connective tissue graft from the tuberosity?
Yeah, I think we already looked at that question. I think it's a good way to do it. I mean, the tissue is probably a little more stable when compared to the tissue which can be harvested underneath the bicuspid. In most of the cases, it has a weird size for me. I mean, it is good for one edentulous spot in most of the cases, but for me it's not suitable for multiple recession coverage. And it's also, in most of the cases, not really suitable for around implants because of a different size. However, it seems to shrink less, which may be an advantage, but may also be a disadvantage because, well, it is more difficult to nourish it by diffusion. So I think there are indications, for me, not so much in the field of around teeth, but probably in the field of volume buildup of an edentulous site, it is probably a good material to use.
Okay, Stefan, what about derma? This is a cellular or a cellular matrix?
It is actually an acellular matrix. Well, what I know from the process is that a specific process, the cells are removed. It's a cold process, what they told me. So it is an acellular matrix.
So we have one more question from Diego Navas from Argentina. Do you have any experience with different type of this kind of membranes? And do you have any other kind of membrane, any other kind of xenograft like derma in Germany?
Yeah, we actually, of course, we have different materials. We, of course, have the mucograft on the market, which is a completely different material, in my opinion. A good material, but for me, in different indications. We have some sort of different porcine matrices, which are pretty much, I would say, in the same range of indications than we see it. So I would say for the fibrous membranes which we have, which are, most of these are porcine, well, porcine dermis. I think the field of indication is pretty much the same as we just described it here. Of course, alloderm is something I'm not using because it's not on the market. I've used it in my time in the US. For me, it is sort of, from the handling, quite similar. I had the feeling that the relapse is a little bigger when compared to these kind of materials. What is your take, Antonio?
Yeah, same. I totally agree with you. I have to be honest. I never used. I mean, I used just two type of xenograft for soft tissue augmentation: alloderm and derma. And I have to be honest. I strongly prefer derma over the alloderm. And this is just a clinical feeling, nothing that can be demonstrated or nothing that has been studied about, but it's just my personal clinical point of view. So I have one more question about Yvonne Evans, from Yvonne Evans. It is referred to your lecture, Stefan. You mentioned earlier that patient base was younger. How does the older patient fare with this type of surgery? I think she is referring to the tunneling technique.
I'm not sure if I really said that. When I said it, that it was maybe a misinterpretation. Of course, we're covering recessions in a lot of cases in young patients because, I mean, this type of, well, let's say, disease comes up rather early. I would not see any difference in the age of the patient. We would treat most of them pretty much the same. Of course, I mean, if they have some kind of medical history, you have to be more careful, especially when it comes to harvesting of pellet. But I would not see a big difference in these kind of patient groups. What is your thinking, Antonio?
Yeah, I mean, I don't think that we can have any difference between younger and older patient. probably one I mean quite interesting question would be what would you prefer, thin or thick biotypes for the use of derma, or when would you suggest the use of derma, with the thin biotypes or thick biotypes?
You actually putting the finger into the wound. This is the most important question. Very difficult to answer for me. Well, actually, we started with thick biotypes because, of course, you have a learning curve with every material. We know we have more connective tissue in these cases, and we rather want to be on the safe side. We've been using it now also around thin biotypes because, of course, the field of indication in these patients recovering recessions. I think it still works. In these cases, I would always add something like a filler or something, not a filler, a wound enhancer, like I told you, like an endogain or something else you have in this field to improve the healing. And I would be even more careful in suturing. I think in thin biotype, if you suture with too much tension and with the dermic membrane, I have the feeling that it goes very quick, that you just cut off the blood supply of the flap. So I would say today, in my phase of learning curve, still I'm working with a lot of thick biotypes. I think it can be used around thin biotypes, of course, with much more care and much more careful than we use it around thick biotypes.
Yeah, and I have one more. I mean, I would like that you just underline if the use of derma needs primary soft tissue closure or not. I would just say that it would be mandatory to have a soft tissue primary closure over derma. It is correct?
Right, right. I would say that. I mean, actually, we need primary wound closure around connective tissue grafts. If we are honest, I mean, then we just get more predictable results. I mean, you can let a little bit just heal by secondary intention, but I mean, if you cover everything, you're more on the safe side, and this is even more the case for these kind of membranes. Totally agree.
Yeah, yeah, great. So I have really an intriguing question for you. What is your experience with a mucograft? What is your experience with a
Actually,
mucograft?
yeah. Our experience is also, I mean, rather good with these materials, however, in a different field of indication. To be completely honest, I mean, these materials, they have to be used in different fields of indication. Mucograft is not a material which improves the soft tissue volume. It's a material which might be able to increase the amount of keratinized tissue, maybe even a little better than the dermic membranes, but it is not able to maintain soft tissue volume. So this is a material for me which can be used if you have a lot of soft tissue volume to expedite the tissue healing, for example, around tissue recessions. I think it's actually an interesting material. I don't know what you think, Antonio, in thick biotype for rich preservation, to sort of use it instead of connective tissue punches or our free gingival punches. I actually like it because it's just much more atraumatic. And I mean, in thick biotypes, I mean, you probably don't need really these huge free gingival grafts from the palate. So this is rather the field of indication for these materials. I don't think they hurt each other too much because every one of these materials has its special field of indication. This is because of well, the material properties they have. What is your idea on that? I am really thrilled. What do you think? The expert in the field of ridge preservation.
Yeah, I am an expert in the field of ridge preservation. Never used mucograft, I have to be honest, because I don't think that mucograft can really be useful for ridge preservation. But it probably, you're totally right. I mean, the indication for the use of mucograft and derma are different. So you can choose the right material, depends by the type of defect you are going to treat. I have one more question for you now. I mean, if you have if you need just to increase volume and keratinized tissue, over implanting the static zone, would you use still, I mean, autogenous connective tissue, or would you use the derma?
It also depends. I mean, it is probably a little unfair because we just have much more experience with the connective tissue grafts. I mean, to be honest, if it really depends on the result, if I have a young patient, high smile line, and I really want to achieve everything, I'm still back with connective tissue grafts. I mean, if I'm having a situation where I have a little bit of a lack of volume, like you saw it in these cases at time of second stage, and I want to get back a little bit of volume, then I would go to the dermic membranes. And if it's really a demanding zone, I would combine it with some sort of a wound healing enhancer. I mean, this is probably how I would do it today. Maybe in a year, in 2 years, I've increased more of my more clinical feeling for these materials. But today I would see it like this. Connective tissue still is, if it really counts, it is the material number one for me. In most of the other indication, I think we can really rely on the dermic membranes.
Yeah, that's what I really think. So thank you for your answer. And we have a question from George Petrea. So the question is, can I use these membranes to cover a buccal implant recession? Almost the same question I made you.
Should I give you a quick answer?
Yeah.
No.
Please.
I don't think that. I mean,
Okay.
I don't really think that you can use connective tissue in a predictable way to cover implant recessions. I mean, if you have a great technique, Antonio, tell it to me. I have never really succeeded. I have cases which work rather well. I have cases which don't work at all when I cover implant recessions. If I would do it, I mean, I have a feeling 1.5 to 2 millimeter of recession coverage is possible around an implant, and everything else is just unpredictable. So for me, this is not an indication for a dermic membrane.
Yeah, I agree with you. So, so we have a question from Pedro. What is the name of instruments you use to make the releasing of the flap in the tunneling technique? I think he's referring to the small instrument you use to perform the tunneling technique.
Yeah, they are called tunneling knives, and they're available from more or less most of the companies today on the market. So tunneling knife, they are sharpened on the tip. We use a sharpening stone in order just to, well, sharpen them, and well, they are really suitable for undermining this buccal complex. Tunneling knives.
Okay. And so we have probably the last question. And the last question is if you sometimes combine the two products, that means the derma with the autogenous connective tissue graft. Do you sometimes combine this type of material?
Yeah, actually, very good question. Because very recent. We start using these materials as an addition to connective tissue graft when we have, for example, huge recessions and we are not able to, well, harvest enough connective tissue. I mean, you know these situations. You just are able to cover 2 or 3 recessions, and then we use the dermic membranes around the most mild recessions of these cases, and use a connective tissue around the more severe area. So yes, we started to combine these techniques. However, I cannot really give you too much detail because this is just started. And we also used it as an addition, so around implants, like the membrane on top of the implant, then a little bit additionally in the orifice with connective tissue graft. Very recent and rather, I would not call it experimental, but really something we've been start getting our experience. So I would say, yes, if you don't harvest enough connective tissue, use it in the mild recessions and use the harvested tissue in the severe recession. This is definitely possible. Do you have any experience with that, Antonio?
No, never combined, to be honest. I never combined. Never combined. So, Stefan, we almost are going to close this session, and I would ask you just if you are able to summarize in a few words your lecture. Can you give us a summary of your lecture, just saying where the derma should be used, where not, and where we should be still really careful about the use of derma?
Yeah, great. I think the first thing which we should really underline that it is a safe material. It is safe. We have histology. There's no foreign body reaction. It is really something which we can use in our patient. The second thing is that these materials, they work, but you will have a learning curve. For me, I think the best starting point is volume augmentation at the time of second stage. For example, in the bicuspid area, if you have these kind of concavities, there these materials work very well and very reliable, very predictable to augment 2, 3, 4 millimeters of tissue in these cases. Now, stretching even more a little bit the envelope is when you go to the field of recession coverage, because now you have to be careful of the tension. These materials work well in mild gingival recessions up to 2 to 3 millimeters, because then you don't need so much tension for the flap in order to move it up to in the coronal aspect. The deeper the recession get, the more careful I would be. For me, this is it in a nutshell, and the most two important clinical tips is be careful with suture tension, especially if you use these materials, and make sure you're not using them too thick, because they are swelling up. They will be a little thicker at the end of the day, and they will just sort of, well, take away blood supply if they swell up. This is what I would say in a nutshell.
Okay, great. So I really thank you. And I can say that you did really a great lecture. I really appreciated it. I really improved my skills in soft tissue management. Before closing, I want to just give you an idea where I am. At the starting, when you started your conference, you told us that you are in Würzburg and is going to you have some snow. I'm on the west coast of Italy. I am 300 meters from the sea, and the temperature today is 20 degrees Celsius. So from the west coast of Italy to Würzburg in Germany, I would just say to Stefan Ficla, and really thank you for this outstanding lecture. Really, thank you very much, Stefan.
Thank you for the moderation. It was an honor to have you as my chairman, and I hope the people enjoyed it. And, well, I wish everyone a nice evening and hope to see you soon around.
Yeah, I'm sure. So, bye-bye. Bye to everybody. Thank you again to Professor Ficla. Bye-bye.
Ciao. Thank you.
Ciao. Ciao.